So it's my great pleasure to introduce Professor David, who has been actually my boss. Not many people have been my boss, because normally I tend to get money from the MRC these days. But it was a great privilege to have him as a boss who was very kind to pay my salary when I didn't have one and I was in between trying to get some funding. But then he decided to leave the Institute of Psychiatry, and probably the experience of being my boss was toxic enough, and decided to go to UCL, where now is the director of it's called the Institute of Mental Health, and which is very appropriate for this location because we are actually in the Royal Institute of Mental Health. Funny enough, for a place that doesn't have a royal family. So I'm sure you will all enjoy, and it's great to have actually Tony, because we often don't cover neuropsychiatry, which I think is something that for all of us is essential in our clinical practice as well as in our research understanding. So I won't take any more time, and Tony, lovely to have you in Palermo.
Thank you very much, Marta. Thank you.
Sit.
No one's ever Marta's boss. No, it doesn't happen.
True.
Okay, thank you very much for coming. So I'm a neuropsychiatrist, but I'm also really, my long-term interest has always been in schizophrenia and psychosis. And that will come out a little bit in what I'm going to talk about today. I'm just going to pick 2 or 3 topics where there's been quite a lot of recent interest, where the border between regular psychiatry and neuropsychiatry is quite blurred, and I think it's an area that informs our understanding of psychiatry, neurology, and the brain for all concerned. Okay. So first of all, neuropsychiatry is a branch of psychiatry that looks at the psychiatric consequences of brain damage or disease. But it's a branch of psychiatry. It's not a branch of neurology. So it's still about the bio-psycho-social approach. And whatever condition we're studying, it's always the challenge to bring together all of these elements. So you might say, what's more important, the analytic couch or the brain scanner? And in fact, it's trying to make use of both of these techniques, as it were, for the benefit of our patients. So you could say, now, which one of these people is a neuropsychiatrist? This chap here or this chap here? You probably recognize this one, Sigmund Freud. Does anyone recognize this one? Okay, this is Wagner Jörg, also Austrian, lived almost exactly the same, is an exact contemporary. He's the only psychiatrist to win a Nobel Prize for a psychiatric treatment. The psychiatric treatment was the infection with malaria of patients suffering from neurosyphilis. So he gave people with neurosyphilis malaria to try and treat the malaria. Now, I don't know whether that's in the Maudsley guidelines at the moment, but it's not really a treatment that stood the test of time. And he wasn't a very pleasant man. He was a Nazi sympathizer, and he didn't really have much compassion for the patients he was treating. But it does remind us that both scanners and couches are important. So the first controversy I'm going to talk about is Parkinson's disease and hallucinations. So people who are in old age psychiatry, in liaison psychiatry, will be very familiar with this as a clinical problem. The patient with Parkinson's disease who has really florid hallucinations, often visual hallucinations, but they can be in any modality. So we all know what the basic symptoms are of Parkinson's disease, the tremor, the bradykinesia, etc. But there's increasing interest, and we all know that the basic pathophysiology is reasonably well understood as a diminution of dopamine in the substantia nigra as part of a neurodegenerative process. Obviously, it's more complicated than just dopamine, but that's the essence. And the treatment, of course, is dopamine replacement. But we're becoming very interested in the so-called non-motor symptoms of Parkinson's disease. So this includes things like depression, which is very, very common in people with Parkinson's disease, as well as psychosis, but also symptoms like constipation, insomnia, and so on. Again, extremely common symptoms. And the extent to which they are part of the Parkinson's syndrome is something we're increasingly beginning to understand. So, of course, a person who develops Parkinson's disease is entitled to feel depressed. But we find that when you go back through general practice records, it's often the case that the person was presenting with symptoms of depression between 2 and 5 years before they eventually present with the tremor and the slowing, etc. So it does seem like it is part of the disease process, often preceding the more obvious neurological manifestations. So, but hallucinations is a very noticeable and distressing symptom. And these are visual representations of hallucinations. These two are from the Bethlehem Museum, where we work, from patients trying to depict what it's like. So how can you try and tease out, very much going on from the previous talk, what are the effects of medication from what's the effect of the underlying condition? Well, this is another famous hospital, not the Maudsley Hospital, but the National Hospital for Neurology and Neurosurgery, as it is now called, what used to be called the National Hospital for Nervous Diseases and Epilepsy. So this is in North London, connected to the university that I now work in, and they have an archive of old records. So using that archive, it's possible to look at the case notes of patients with Parkinson's disease before L-DOPA was discovered and introduced in the early 50s. So we looked at over 100 patients, and of course, in this very elite, famous hospital, the quality of the case notes was often very good. Patients were very carefully assessed. That doesn't mean they were treated particularly well. They were just very well assessed, and then nothing much more was done. So out of all of these patients, very high proportions had the tremor, rigidity, and bradykinesia that we associate with Parkinson's disease. There's quite a lot of depression, cognitive impairment, and other symptoms. But when it comes to hallucinations and delusions, we didn't find a single case. And we were also interested to try and exclude the Parkinson's syndrome that follows encephalitis lethargica, sleepy sickness, which I'm going to talk a little bit about, which is well known to produce ocular gyrate crisis, other eye signs, as well as psychosis and delusions. Yeah?
Tony, what about changes in the swallow reflex or esophagus mobility, which is something that recently was brought up by a GI specialist that I went to see that, my dad actually had Parkinson's, and this was one of his first symptoms, which I didn't think had anything to do with then his later Parkinson's, but the GI physician said that it can be commonly preceding change.
Yeah, I'm not familiar with that as an early symptom of Parkinson's, but the number of early symptoms, the list is ever growing. We didn't look at that in this study, but it would have been quite interesting to go back. But the point is, the clinicians at the time were quite sensitive to picking up other symptoms, but they still didn't pick up any hallucinations and delusions, which leads me to interpret that the very common appearance of hallucinations in Parkinson's disease is a consequence of the DOPA treatment. Okay, here's another area of controversy, and it's around the autoimmune encephalitides. So these have been known about in neurology for at least 50 or 60 years, and there's very many variants. Some, of course, are to do with infections, some are to do with immune reactions, and they've been known about for some time. But we're discovering a new group that are due to neuronal surface antigens and the immune response to them. Now, this is, in a way, the paper that's caused all the trouble, because these conditions, as I will show you, have been recently discovered, and antibody tests have been recently developed. So my good friend and colleague Mike Zandi, who's a neurologist working with the first episode psychosis team in Cambridge, said, well, I wonder what happens if we just take a group of our patients and see whether any of them have these autoimmune brain antibodies. And so they looked at about 40-odd cases, and they found 4 who had the NMDA receptor autoimmune antibodies. Two or 3 patients, depending on where you draw the sort of threshold, and another one with this VJKC, the potassium channel autoimmune antibodies. So there wasn't anything particularly unusual about the patient's presentation. They all had delusions and hallucinations, as you would expect. Some were more badly affected than others. But that's 4 out of 43 cases. So the question is, well, how many more of our supposedly idiopathic cases of psychosis and schizophrenia are actually due to the effects of an autoimmune encephalitis, which would require a different form of treatment? So that set the ball rolling. So just to step back, so this particular group of encephalitis due to the NMDA receptor, which is connected with the glutamate system in the brain, antibodies that attack that receptor, they were discovered by Joseph Dalmau in 2007. And then since then, there's been a whole load of other neurologically relevant receptor antibody syndromes described. Glycine, the AMPA receptor, GABA receptor, et cetera, and these are the potassium channel receptor sites. And so, in general, what can we say about these encephalitis syndromes? That the antibodies bind to the key, either the ion channel, the receptor, or the associated proteins on the neuronal cell surface. They then result in acute or can be subacute presentations. You can detect the antibodies in the serum and the CSF, usually, although I'll come back to that's quite a complicated matter. They tend to cause cognitive impairment, seizures, movement disorders, and muscle disorders. Patients, can respond to immunotherapies, and some of them even occur in children. So this was a book written by Susanna Cahalan, who's a journalist, and she presented with an acute sort of schizoaffective type of psychosis. But she was seen by a neurologist who made the heroic and brilliant diagnosis that no, this wasn't psychosis, this was encephalitis. And she was treated appropriately and wrote a book about it, and they even made a film about it. I haven't seen the film. I'm told it's really terrible. The book is quite good. So although she is very well informed about psychosis and has subsequently written books on the history of psychiatry, you can't help thinking that it's a sort of kind of an attack on psychiatry. So psychiatry wants to just put you away in an asylum, fill you up with the sort of drugs that David Taylor was telling us have quite bad side effects, and then forget about you until a heroic doctor comes and saves you and says, no, that's the wrong diagnosis. So there's a bit of that going on. But on the other hand, it's important to make the correct diagnosis and give the right treatment. So going back to the original report from Dalmau and colleagues, they're describing this new form of encephalitis. And it's in Lancet Neurology. So this is aimed at neurologists. But when you look at, well, what are the symptoms? Yes, you have an acute encephalopathy, often following a kind of flu-like illness. But the most common symptoms are, quote, psychological, followed by movement disorder, followed by seizures, followed by autonomic dysfunction. There's an association with a rare kind of ovarian tumor, which triggers the autoimmune response in some patients. But when you look at the psychiatric symptoms in general, there's a lot of anxiety, agitation, psychosis, and in particular, catatonia. And it's found that in this large series, 77% presented initially to the psychiatric services. So there is something that resembles an acute psychiatric syndrome. And then we've now had more studies looking in more detail at the kind of psychiatric symptoms that these encephalitides present with. And just to cut a long story short, so this is children, teenagers, and adults over 18. The blue bit of the pie is, quotes, behavior abnormalities. So most of these, we'd say, are psychiatric presentations, very broadly speaking. So in young people and adults, it's the majority. And then you have things like movement disorders, seizures, cognitive symptoms. And this was a study that we did looking again in more detail at the phenomenology. So you do get positive and negative symptoms, but the cognitive symptoms, confusion, disorientation, are the most prominent. And, quotes, bizarre behavior, thought disorder, again, very common, and disturbances of mood, extreme disturbances of mood, hypomania, mania. So it's a kind of a psychotic syndrome. It's not identical to the typical presentation of, say, schizophrenia. You know, the cognitive symptoms, the predominance of them should give us pause for thinking, is this something more brain-based? And then here's another similar survey. Again, you can't see the detail, but the biggest chunk of symptoms are in terms of agitation, aggression, disorganized behavior, etc. And then the more strictly neurological symptoms are slightly less common. Okay, so what's actually happening microscopically? So here's the healthy synapse, but you have antibodies forming to the receptors in the glutamate system. And then the postsynaptically, the receptor is sort of invaginated and incorporated inside the cell. So it's taken out of circulation in the sense of it's no longer able to operate as an effective receptor binding site. So it has the effect of reducing the glutamate tone. And now there's lots of drugs that do that, ketamine being one. So it's a little bit like taking ketamine. It causes that kind of psychotic reaction by taking the glutamate receptors out of the system. But as I said, there's now lots of different autoimmune receptor conditions. The NMDA receptor condition is the most relevant for psychiatry and is probably the most common. Second most common is the LGI1 antibody disease. And there are various risk factors. It often presents very gradually and confusingly with seizures, some fluctuating cognitive problems, fluctuating psychotic symptoms, and then later in life, it begins to become more clear that this is a neuropsychiatric condition with abnormalities being now picked up on the MRI scan, which wouldn't have been there at an earlier time. But even so, the presence of seizures should make us think this is not just a typical psychotic condition. So it's the NMDA and the LGI1 encephalitis that we have to be most wary of. The others are really very rare. But just for completeness, here's a table, and you can, Tom Pollock, my colleague at the Maudsley, has written some very important articles, and this is a very useful article where he goes through them one by one. So at the top is the NMDA receptor, then the LGI1, and you can see that they can present very much neurologically. So Morvan's syndrome is a condition, it's a neuromuscular condition of hyper excitability. So again, that wouldn't really confuse a psychiatrist. The psychiatrist saw a person whose muscles were in a state of constant rippling activity. You would think, I need to get a neurologist to see this patient. But when they present just with confusion and hallucinations, that's when it becomes more difficult. And as I say, there's lots of now, a whole host of different receptor conditions. So it becomes quite a challenge to make a diagnosis, and helpfully we now have diagnostic criteria, and this is the Gauss criteria after the first author. And this is, if you look at this panel here, I don't know whether you can read it, but this is for probable anti-NMDA receptor encephalitis. And it's still predominantly a clinical diagnosis. So it's a rapid and acute or subacute onset of psychiatric disturbance, or sleep disturbance, speech disturbance, or seizures, or movement disorders. And you need 4 out of these 6. So some are very neurological, but some are psychiatric. In terms of the laboratory studies, an abnormal EEG, not very specific, rather non-specific, and abnormal CSF, again, rather non-specific. And you need just one or other of those. And then you've got to exclude other disorders. But to have a definite diagnosis is based on the immune antibodies being detected. And here it says they can be detected in the serum or the CSF. But I think nowadays we've got to know that perhaps, like the study of Zandi in Cambridge, there is a certain low level of positive antibody in the serum, even in healthy individuals. So false positive rate is perhaps 5 or 10%. So to avoid falling into that trap, one needs to get a CSF serum sample, which of course is complicated in people who are very disturbed and in a psychiatric setting. So those were the criteria for the encephalitis per se, and then Tom Pollock has published criteria for autoimmune psychosis. And again, if you look at the probable criteria, you have the psychotic symptoms that are acute or subacute. You have the abnormalities in the CSF or on the MRI scan or EEG. And it says here, the presence of serum antineural antibody detected by cell-based assay is part of the probable diagnostic criteria. But now we'd say that it's really not enough to have just the serum antibodies. We need to have CSF to really confirm the diagnosis. Not always possible. So sometimes you have to make the best diagnosis based on the clinical and routine laboratory criteria. Okay, so basically it is a condition that psychiatrists general psychiatrists may come across. Be aware that your sort of initial training, where we were all taught how to distinguish, quotes, organic from non-organic conditions, the presence of seizures and confusion remain very useful pointers to an underlying neurological condition. It still may mean that the person's biggest problems are their psychosis and behavioral problems, so they still may need to be looked after in a psychiatric setting, but with our neurological colleagues, because they're going to take a lead role in the treatment. So what is the treatment? Well, obviously, you treat the underlying cause, and in these autoimmune conditions, it's usually immunosuppression with steroids, although, of course, we know that steroids can have a lot of psychiatric side effects. Immunosuppressive therapies, and there's a lot of monoclonal antibody-type treatments as well as generic treatments. They all have psychiatric side effects. And plasma exchange is also needed, but that obviously happens in the context of the general hospital, indeed the intensive care unit. So also symptomatic treatment for seizures, as you would normally. Benzodiazepines can be very useful for catatonia and agitation. Antipsychotic medication, well, often if a person is very, very disturbed, in a way one can't avoid using antipsychotics, but it's best to use the atypicals because you can precipitate neuroleptic malignant syndrome, for example, and you can induce seizures. So you've got to be very gentle in using antipsychotic medications. ECT may even have a role. At the moment, we'd say there's no evidence for maintenance antipsychotics, that after the person recovers from the acute episode, usually whatever schizophrenia is, this is different, and there's not the same inevitability of relapse. So you probably don't need to have maintenance antipsychotics. But what I put here is, because we're talking about controversies, and this is really, for me, is my main concern. If we go back to the Susanna Cohalan Brain on Fire, this idea that you don't have psychosis or schizophrenia, there's something else that's, quotes, treatable, is a very powerful idea. And families often have learned about this and will insist that you keep doing more tests, that you refer the patient to more and more neurologists and immunologists, and they don't believe you when you say, look, I'm treating this person with the best treatments we have, it's for their symptoms. The psychiatric services are best placed to look after people in the community and provide long-term support. But they're still saying, no, we want you to do some more tests, the latest brain scan, the latest blood test. So that can be quite difficult to negotiate, taking account of the patient and their family's best intentions, but not missing out on giving the patient the treatment that they really need. Okay, here's another area of controversy, the effect of COVID-19 on psychiatric conditions. Now, I mentioned when I was talking about Parkinson's disease, this condition of sleepy sickness, encephalitis lethargica, which followed, it appeared to follow the Spanish flu epidemic. And so when the COVID pandemic hit us, a lot of neuropsychiatrists were thinking, now, are we going to be left with this legacy of long-term neuropsychiatric conditions? People who may have recovered from the respiratory disease and then developed a neuropsychiatric disease. So again, that was quite a strong concern at the beginning of the pandemic. So to what extent has that turned out to be true? So this was probably where the Spanish flu epidemic started, nowhere near Spain. In fact, it was in Kansas, US. where they had a lot of chicken farms. So it was probably a kind of bird flu variant that got into the human system. And there was, an army camp nearby where people lived in close proximity, the soldiers in dormitories, so very conducive to the spread of infection. And then they all came over to help in the First World War effort, and according to some historians, that's what spread the so-called Spanish flu epidemic. And as I say, it was widely believed that people who recovered from the Spanish flu developed this encephalitis lethargica, and this has been was described by von Economo. It was characterized by, as well as excessive sleepiness, these ocular gyrate crisis, movement disorders, dystonic movement disorders, turned into a brilliant film where Robert De Niro playing a patient and Robin Williams playing Dr. Oliver Sacks, using L-DOPA treatment for the first time in a Parkinson's-related condition, and so the person, as it were, wakening up for the first time. The film and the book was called Awakenings. And of course, it turns out that that was rather temporary. The person did wake up, but then a little bit like the tardive dyskinesia that we used to see a lot in the treatment of schizophrenia, new kinds of movement disorders began to predominate, and in this case, completely overwhelm the beneficial effects. Anyway, that's a little bit of a side issue. We still get sporadic cases of encephalitis lethargica appearing now. So people in universities, specialist hospitals for neurology will see the odd case. And what's interesting is it does have quite a characteristic pathology. You can see here, it's very much in the midline. Here in the midbrain periaqueductal gray area, there's inflammation. In the putamen and thalamus, and which resolves. So this is what encephalitis lethargica looks like. And we don't see that in people who've had COVID-19, thank goodness. So what is the link between encephalitis lethargica and Spanish flu or other pandemics? Well, when you really scrutinize the historical record, you find that this sleepy sickness, encephalitis lethargica, started to appear around 1916, 1917, which is definitely before Spanish flu appeared. So it was already there. There wasn't really any evidence for an acute viral infection at the time, and we've since been able to exhume people who died of Spanish flu and who then got the encephalitis lethargica. And the people who died of encephalitis lethargica don't have evidence of the Spanish flu virus in their brains. Now, that doesn't mean that it wasn't some kind of autoimmune or infection immune cascade, but it wasn't simple brain infection with the virus. And so far, touch wood, we're not seeing reports of an increase in encephalitis lethargica post-COVID-19. Maybe it will still yet to appear, but it doesn't look like it. So what does COVID do in the brain? Well, we know that it can directly infect the brain, although that in itself is very rare and is usually in the context of immunosuppression. Much more evident is the sort of vasculitis, vasculopathy that occurs, and that can have downstream consequences on the brain, causing mini strokes or large-scale strokes. Then you have the effect of the immune reaction, the so-called cytokine storm, which can have psychological and psychiatric effects. So there's no doubt that COVID-19 can have neuropsychiatric consequences. And sometimes they can be very severe. Again, this is rare. It's probably 1 or 2% of cases of cases where there's severe respiratory disease. Only a small proportion of them have neurological disease, and it tends to be strokes, vascular-mediated problems, rather than the sort of midbrain inflammation that we saw in encephalitis lethargica, although you can have widespread acute disseminated encephalomyelitis as well. So it has many neurological consequences, but they're all rather rare. Most common are kind of vasculitis type presentations. So what about the slightly longer term effects in terms of psychiatric disorders and neuropsychiatric disorders? Well, this is work by Maxine Taquet, who's a psychiatrist who works in Oxford, and they've made use of this huge database from a medical provider, mostly in the US, but also in Asia and a few in Europe. So they're sort of routine medical records that they've analyzed to see what the consequences were of people who presented with COVID-19 and other respiratory infections. So what they're looking at here is any increase in the rates of dementia following COVID-19. And what you have here in the blue line are people who are hospitalized with COVID-19. So obviously they had quite a severe condition versus those not hospitalized. And there's a very slight increase in dementia in that group. What this is the rates of dementia in people who presented with an encephalitis due to COVID. So again, no question that people who've had an encephalitis then go on to have longer-term evidence of brain damage or degeneration. But it's very much confined to this already small group who've had the brain disease of COVID. So even quite severe respiratory COVID has minimal effect on long-term neuropsychiatric outcomes. Now, what about psychiatric disorder? And these are all lumped together. And you can see that there is definitely an increase in all psychiatric morbidity following infection, even when it wasn't so severe. But again, if it was severe enough to cause an encephalitis, we get a definite increase in probability of having one of these disorders. But of course, these disorders are common anyway. So even a 10% increase has got to be taken in that context. So, but what about the long-term effects? Now, I'm not sure how well you can see this graph, probably not very well, and please do look up the original paper if you're interested. I'll try and pick out what's going on. So what these graphs all show, the different conditions. This is mood disorders, dementia, cognitive deficits, and then here you have muscular junction problems, anxiety, Guillain-Barré syndrome, psychosis. And so mostly you can't see the difference between the blue and the red lines. The red line is COVID, and the blue is another respiratory condition. So where the two lines don't separate, which is most of the time, there's no specific increase due to COVID compared to having any other serious illness. But in some conditions, there is a separation, like dementia, where the risk for dementia is definitely higher following COVID than following other respiratory diseases, as it is for neuromuscular junction problems, and possibly is for psychotic disorder. But what this study does that the others don't is they've gone 2 years follow-up to see what happens. Now, I will try and redraw this graph for future, but what these graphs are showing is how long it takes for this increase to come back down to normal. And perhaps if I just describe it, that basically when this line hits the straight line going from an odds ratio of 1, that means it's got back to the baseline. And so in most cases, even though there's been an increase, it gets back to baseline. There's an exception that in dementia, it doesn't seem to get back to baseline. So in other words, the increased risk for dementia persists. That might also be true in psychotic disorders, but when it comes to anxiety disorders and many of the other conditions, it's coming back down to baseline. So in most cases, after 2 years, we're back to where we started. But it may be that we're going to see a little bit of a spike in the number of cases of dementia and possibly even psychosis following COVID. But it's probably only going to be in those people who had a neurological complication of COVID in the first place. Okay, so let me summarize. We talked about hallucinations in Parkinson's disease and the non-motor symptoms of Parkinson's. We talked about these new set of diseases, the autoimmune encephalitides, and perhaps related to that, the neuropsychiatric complications of COVID-19. So we can conclude that many of the non-motor symptoms of Parkinson's disease are part of the disease, but hallucinations are probably a consequence of the dopamine therapy, either in terms of direct agonist therapy or replacement. So obviously there's a real challenge there to get the balance between the beneficial effects and the side effects. Autoimmune encephalitis, despite the hype, it really is a new group of diseases that general psychiatrists as well as neuropsychiatrists need to be aware of because they often present with behavioral abnormalities, but we shouldn't lose our clinical skills and look out for the markers of neurological disturbance, and the presence of seizures and confusion in particular should raise suspicions. And we are going to probably have to get more used to doing CSF analyses to exclude the diagnosis. And then in COVID, I think we have yet to see the full consequences of the pandemic as neuropsychiatrists and psychiatrists. I think the anxiety and depression that we saw, as it were, inflamed during the pandemic has probably already disappeared. But we may well see a bit of a legacy in terms of psychosis and dementia. What we haven't seen are the really hardcore neurological consequences like encephalitis lethargica that was attributed to the Spanish flu pandemic, probably incorrectly. And we're not seeing something like that following COVID-19. Thank you very much for your attention.
Thank you very much. Oh, questions are ready.
Hi, thank you. For the autoimmune type psychiatric presentations, in a rural and remote area where access to neuropsychiatry is very difficult, what is the best thing we could be doing to try to rule these out as not a general, normal psychotic presentation?
Yeah, a great question. I mean, the work I'm talking about is biased because it's come from large centers where there's, huge infrastructure. I mean, as I say, I think clinical skills are still very important, and seizures are a red flag, confusion, movement disorders also in someone who's not already been treated with antipsychotic medication is a red flag. Steroids are available in all hospital settings. I think the serum antibody testing is quite widespread now. It would probably need samples to be sent to a university center. Same for the CSF. But it obviously is going to be very difficult. But in fact, the yield from, say, MRI scans is not all that great. And even the humble EEG, it's probably of more value than an MRI scan. So I think there is quite a lot that you can do. Obviously, if there's a strong suspicion of an autoimmune cause and the person has to have powerful immunotherapy or plasma exchange, then they obviously would need to be transferred, if possible, to a larger center.
Hi. And I was wondering about autoimmune encephalitis course, if it will inevitably show its true neurological nature, or if it, in some cases, it remains just with psychiatric symptoms, and so therefore, are we treating these people for years, have been treating them as schizophrenic when indeed they are something else?
Yeah, that's a great question. And in a way, that's the biggest controversy, because we don't really know whether the patient with what seems like an ordinary chronic psychotic condition, who nevertheless has positive antibodies, is that a false positive? Or is it genuinely a different kind of disease? And I think we really don't know the answer. And I think you might then say, well, let's see if we can find the antibodies in the CSF, and you may not find them, but then it may be because the person is no longer acutely encephalitic. So the definitive answer to that question is we really don't know. But I would tend to just try and treat the patient in terms of their presenting symptoms. And if they seem to need long-term support, try and provide it. If they seem to need long-term antipsychotic medication because they've got chronic residual psychotic symptoms, then you have to treat that. And in the end, maybe we'll learn that a certain proportion of people with what we call schizophrenia actually have an autoimmune condition. But if that is the case, it's probably a very tiny percentage. Giris.
Thank you. Great talk, Tony. Thank you very much. I learned a lot. I must say I'm a bit baffled by those criteria. Mm-hmm. And I'd like to understand the algorithm. Like, when am I supposed to do a serum antibody test? Mm-hmm. What should be my Bayesian prior, as it were? Because if the false positive rate is 10%, from that, then I was just calculating. I was just doing some basic calculations on the basis of that. It seems that I would be doing something interventional in a number of people where I shouldn't be doing it. Mm-hmm. And so that's one concern. And the second one is, how certain are we, if we find CSF antibodies, that they're causal? That it is really autoimmune. Is that the gold standard? And the third one is, you mentioned epilepsy. So the priors you have for psychosis, if you know that someone has epilepsy, is quite high, isn't it? Mm-hmm. Regardless of an autoimmune encephalitis, right? If someone has epilepsy, their probability of having psychosis is much higher. Of garden variety psychosis, isn't it? That's what I was taught by you, so years back. So like, again, it just is confusing, because then you use it as a criterion in order to perform all these tests, and then you are using potentially psychotogenic substances after that, like steroids. So I just find it, I think many of us practitioners would find it confusing. Should I get, well, you catch my drift. Sorry, I shouldn't.
Yeah, I mean, that is why it's so difficult. And we've learned from our mistakes. We've learned that accepting a weakly positive serum antibody test as proof of an encephalitis was a mistake. We now want to go, if we've got particularly if it's a weak titer of serum antibody, we need to get the CSF, which is a much higher, much lower false positive rate. I think someone with is already suffering from epilepsy or seizures who then presents with psychosis, that is a complex clinical conundrum. But here we have, I think partly it's the acuity of the onset of the condition. So where someone has had growing prodromal disturbances, becoming disaffected, developing paranoid ideas, that's not the scenario. This is someone who's actually functioning quite well and over the course of a few days become acutely psychotic. Now that could still be the way psychosis presents, but that's the first index of suspicion. And then in the context of that acute disturbance, they have a seizure. That's completely different from someone with epilepsy who develops a psychosis. So it's the order in which these things occur. And the continuing confusion, cognitive impairment, and bizarre behavior, which isn't in the context of a clear delusion and hallucinosis, where you can to some extent understand why the person is behaving the way they do. They've put tinfoil over their radio because they think they're getting messages being beamed into their brain. It's bizarre behavior, but it's sort of understandable. But someone who's just simply crashing around the place, incontinent, breaking the furniture, unable to give any kind of description, that's the sort of abnormal behavior, agitation, that even a neurologist notices as being abnormal. So those are the sort of things that help to at least restrict our index of suspicion. But really the fact is it's a very complicated and difficult clinical scenario, and you need to speak to your colleagues in neurology and neurophysiology, and you really need to sort of have case discussions and try and come up with the best way forward, causing the least harm. So that's the kind of phase we're in at the moment.
Tony, I actually have a question that goes more back to what you said, that perhaps in setting where you can't go to the lab for some of the investigation, you need to use sort of clinical history taking skills. Say you have the chance to take a collateral history. How important is to know if there is a family history of autoimmune disease? Is it something that, because if I think about other autoimmune conditions which have got nothing to do with this, such as thyroid autoimmune or a general, like scleroderma or LSE, you would want to know if there is a history of autoimmune disease, and you will look for autoimmune, so autoantibodies away from this specific. Is it something that would help? Do we know?
They're not connected with these particular conditions, although actually in schizophrenia there is an increase in autoimmune diseases anyway. So that's another complication. I think that the main thing is to exclude certain rare tumors. So in a female, ovarian tumors, it initially was thought that this was 20 or 30% of cases. It's probably less than that. It's probably 10 or 20%. But even so, that means that, again, in the general hospital setting, you would automatically do an ultrasound to see if you can detect an ovarian tumor. So those are the kind of things you want to exclude. A history of thyroid disease or similar doesn't help one way or the other.
And, because of the ovarian tumor, does this affect, when you look at the rates, the gender differences that we have otherwise when you look at psychosis overall? Or you still have more males that tend to have the NMDA autoantibodies?
So in the young adult group, there is a predominance of females, and it's probably accounted for by the ovarian teratomas.
Thank you.
Hello. Really enjoyed the presentation, and I promise I won't ask a question about autoimmune encephalitis. I was wondering if you could talk a little bit about schizophrenia and Parkinson's. I remember reading your book, and there was an interesting case in there.
In particular?
Just, it seems like there are odds, and where I've come across a case as well, and you don't know what to do, really. It's a balancing act. So do you have any experience there?
So where you think you have proper Parkinson's disease and a psychotic disorder, that it's not just about the medication. Is that, I mean, it's, in a way, it was thought that when the dopamine hypothesis was just being discovered in the 60s and 70s, Tim Crow, one of the most famous psychiatrists to propound the dopamine hypothesis, said, well, you shouldn't ever get a case of idiopathic Parkinson's disease and idiopathic schizophrenia, because one's low dopamine and the other's high dopamine. And then he himself described 4 cases that he found that seemed to disprove that. So it does happen very rarely. And the idea is, well, you know, we think that the dopamine disturbance in schizophrenia is a temporal lobe, temporal limbic increase in dopamine, whereas in Parkinson's, it's about the basal ganglia. So you could have low dopamine in one part of the brain as well as high dopamine in another part of the brain. So it can coexist. But more common, it's the case where the person with Parkinson's disease, you know, needs dopamine replacement treatment as a matter of life and death, really. And how you can mitigate the psychotogenic effects of that. So obviously you try and get to as low as effective dose as possible. But we do find that sometimes, and it sounds very messy, it is very messy, that you have a person with Parkinson's disease and psychosis on a dopamine replacement and an antipsychotic medication. And we find that clozapine is probably the best antipsychotic in that circumstance, probably because of its low affinity to dopamine receptors. But it's really the best antipsychotic to use in someone with Parkinson's disease without, you know, worsening their Parkinson's. But it's another case of very difficult patient group to treat, that you need all the expertise from neurology, rehabilitation, psychiatry, psychology to try and get that balance, that very, very fine balance, as good as you can.
Hello, Tim Foley here. I'm a CL psychiatrist from Australia. Thanks for the great talk. I've had a run of similar cases recently of hallucinations in a person with Parkinson's, advanced Parkinson's disease. And I don't know if I've just assumed it or if I've read it or been taught it, but I assume there was some sort of final common pathway with Lewy body dementia and Parkinson's, and you tend to see the visual hallucinations predominant. I mean, maybe it's academic because you can't really stop their dopaminergic medications, but I had assumed that sort of maybe when the Parkinson's was very advanced and the patient was quite demented, that's when you might see more of the hallucinations. And so I was interested in your interpretation about that.
Yeah, no, very, very good question. So the dementia with Lewy bodies is thought to have the exact same neuropathology as Parkinson's disease, except it extends beyond the basal ganglia into the cortex. And it's characterized by a rather more rapidly progressive generalized dementia with hallucinations and delusions. So there, it probably is still the case that dopamine, L-DOPA or dopamine agonists are going to worsen the situation. But for one thing, people with dementia and Lewy bodies don't respond very well to dopamine, even if they've got tremor and bradykinesia. So there isn't so much a case for using that medication. and the dementia is relatively rapidly progressing, by which I mean, over 2 to 3 or 4 years. And it's in the context of the dementia that you see these hallucinations. Whereas the sort of prototypical case of idiopathic Parkinson's is a person who doesn't have dementia. They might be relatively early on in their Parkinson's history, and it is clearly a relation to their treatment with dopamine that provokes the hallucinations. So you can describe it as being quite separate. Obviously, in real life, the dividing line is much more blurred. But I was really talking about the more uncomplicated Parkinson's patient who doesn't have dementia yet. That's going to be perhaps 8 to 10 years down the line. That they're relatively well functioning, and that their Parkinson's would be well treated with dopamine, except they're having very vivid dreams, they're having very vivid visual hallucinations. And so that's the situation that we really have to try and manage pharmacologically.
Tony, before we break for lunch, this group, well-functioning patients who develop Parkinson, is it the same group when they develop hallucination or other psychotic symptoms that develop problem with gambling, or that's a different group?
No, that's, again, there's overlap. So it appears that the so-called dopamine agonist medications, so they're not L-DOPA, but medications that promote the release of dopamine or act on the dopamine receptor but aren't actually dopamine, they have a propensity to cause impulse control disorders. And the risk factors for that are slightly different. They do tend to be younger male patients, and that's maybe not surprising because it's younger men who tend to gamble. But they needn't necessarily have any hallucinations.
Thank you very much. Any more burning question before we go for lunch? Then otherwise join me in thanking Professor David once again.